lot of the principles, and really I think as you'll see, when we talk about molecular testing, we're moving away from thinking about cancer treatments as we treat ovarian cancer with this drug and we treat colon cancer with this drug, and those things are totally separate, and trying to take a step back and think about the big picture of how we treat cancer. And as we do that, the specific disease site over time will end up being potentially less important in terms of how we treat, and some of the principles of how we treat will be different. So I don't have any relevant financial disclosures, but I am a G1 oncologist. So to give you an example of what that means, so I am both a surgeon and a medical oncologist. Unlike medical oncologists who may receive training and focus on all types of cancers, including blood cancers, hematologic cancers, I just focus on gynecologic cancers, but I do provide chemotherapy and targeted treatment and participate in clinical trials related to cancer therapies. And while most of my examples will be for patients with gynecologic cancers, they really apply to any patient with solid tumors. And I will be discussing FDA-approved therapies, so I can't really cover everything that's experimental, but there's also way too many of those to cover in this kind of talk, but to hopefully give you some tools to be able to interact with your medical provider so that you can think about what kind of testing might be appropriate for you. So we'll be reviewing the role of molecular testing and discuss how this can impact treatment decisions. So classifying cancers, it's more complex than ever. When I think we oftentimes hear terms about, curing cancer or even curing, say, ovarian cancer. Almost every type of cancer is a number of different conditions that are all to varying degrees similar or different. So just for example, in ovary cancer, the three most common cell types are serous carcinoma, mucinous carcinoma, and endometrioid carcinoma. And that really describes how they look under the microscope. And I'm not a pathologist, but I think, you can see in these pictures, there's like different patterns in how these cells look. And that's historically been how we've tried to treat patients with their cancers, is how the tumors look under the microscope and where they come from. So an ovarian cancer might be a serous ovary cancer or an endometrioid ovary cancer or a mucinous colon cancer, but we may treat a mucinous colon cancer very differently than a mucinous ovarian cancer. But now we know that there's a lot more to it. We have a lot of different ways to test tumors for mutations and how they develop and how they progress over time. And there's lots of different levels where this can be looked at. We can look at DNA, RNA, proteins, called epigenetic changes. All these factors impact how tumors behave and how they respond to treatment. So we've gotten a lot more complex with how we evaluate cancers and manage them. So that's really where we get to precision medicine. So precision medicine is broadly categorized as tailoring treatments to the characteristics for each individual patient's tumor, or whatever it is, whether it's treating heart disease or cancer. You can have precision medicine in any type of medical care, but it's really targeting therapies based on individual patient characteristics, and in this case, tumor characteristics, rather than just putting people in kind of buckets of serous ovary cancer, we treat this way, mucinous colon cancer, we treat this way. So there's a lot of promise from this. We might find new and unexpected treatments. We might find that a treatment for a certain type of colon cancer works for a type of lung cancer in some small subgroup of patients, or maybe vice versa. And hopefully we can avoid giving ineffective and toxic treatments if we know that a treatment may not work for someone because they have a certain mutation or don't have a mutation, and that allows us to spare patients toxic treatments that they may not benefit from. But we're really at the dawn of this era of precision medicine. So why is this different? And I'm just going to give to start, and we'll kind of build from here with more complex things, but I just want to sort of build a foundation for what we're talking about. So how is this different from standard treatment? As I mentioned before, imagine you have patients with one patient A, who has a certain type of cancer, an ovarian cancer, and patient B has a colon cancer. They undergo standard testing, so they have perhaps a surgery or a biopsy, and the pathologist looks at the cancer under the microscope and says, this is an ovarian cancer, and this other patient has a colon cancer. They're going to get specific treatments based on these kinds of standard testing. And that's really based on where the tumor came from and how it looks under the microscope. What about precision medicine? So now we're going to imagine that we're going to do some kind of molecular testing. So we have still the same patients that have tumors coming from different places that look different under the microscope. And perhaps we'll find some kind of marker that suggests that both patients benefit from treatment 1, whereas historically we would have never treated patient B with treatment 1. But now we do because of something that we identify with their molecular testing. And then another option would be we have 2 patients that have tumor type A, that we would normally treat both of those patients with treatment 1. But with molecular testing, we find out that one of those patients, even though the tumors look similar, one of them will respond to one treatment better, and another one will respond to a totally different treatment, even though the tumors look similar. So that's really what we're talking about, the 2 main ways that precision medicine can help us in terms of deciding what the best treatments are. We've been doing this to some degree for quite a while. In various cancer types, but these types of tests tend to be very specific to certain types of cancer. Probably the most successful complex treatment planning out there is something called the Oncotype DX, and that's on the left here. You see there's a bunch of different markers for women with breast cancer that help determine a score that helps the patient and their oncologist decide whether chemotherapy is appropriate after surgery and radiation. That's been around for quite a while. Another common one is BRCA testing, which is used for a number of factors. So it helps to determine why the cancer started, whether a patient is at risk for other cancers. So a woman who may have breast cancer who has a BRCA1 mutation would also be at risk for ovarian cancer and may need to either have close follow-up or surgery for that. And now more recently, and also for family members to get tested. And then more recently now, though, is specific treatments based on the BRCA mutation status of the patient in their hereditary and also in their tumor. It helps determine whether someone might be candidate for what's called a PARP inhibitor, which we'll discuss briefly. And we're now finding that that's true for breast cancer, ovarian cancer, pancreas cancer, and prostate cancer, all of which have indications based on BRCA status. And then another example is in non-small cell lung cancer, where EGFR testing helps determine whether a targeted therapy for EGFR mutation patients, whether that's the most appropriate first treatment or not, or whether conventional chemotherapy is the right treatment. So we've been doing this for a while, but it's not that's really still very specific situations. So a lot more targets are coming along all the time, but what we'd like to do over time is develop a broader approach to precision medicine. So what can vary between tumors? So again, stepping back, and why are we doing this? So there's a bunch of different ways that cancer cells can look different beyond just how they look under the microscope, and what can help determine this. These are the ways that I think about this, and when I talk to patients about how we might do some targeted testing to decide what kinds of treatments to receive, I would say that there's kind of 3 broad categories for this. So the first are germline mutations. So germline mutations are inherited mutations. And I think there's a lot of different cancer syndromes that lead to an increased risk of cancer. Probably the most widely known are BRCA mutations, which lead to breast and ovary cancer and some other types of cancer. And another common one is Lynch syndrome, which is associated with colon and uterine and ovary cancer and some other cancers as well. So these are mutations that are inherited. Then there are somatic mutations, which are mutations that are only found in the tumor but not in other cells. And these mutations form after usually after a person's born, and they develop more and more over time, but they're in the DNA of the person's tumor. And then the last thing would be functional changes. And these are a bit more complicated to describe, but they're other changes to the cell that are not written into the DNA that lead to changes in how we treat patients. And these can be quite diverse in terms of how these work. And I'll try my best to explain what kind of these things mean. But sort of the way I think of a germline mutation is, imagine your DNA as a book. And a germline mutation would be like your parent gave you a book that has some incorrect writing in it, or different writing in it, and that has led to a mutation that you've inherited that's been passed on to you through your family, and that can lead to certain cancer syndromes as well as certain treatments now, as we talked about BRCA. The next I would think of are somatic mutations. So when our cells divide, they recopy their DNA, their code. And when that happens, sometimes mistakes are made. There are other ways that this can happen too, but this is one way that this can happen. And think of a scribe, an old-time scribe, like a monk, transcribing a book by writing it out. You could imagine there would be a lot of mistakes made during that. And the same thing can happen in our DNA, and mistakes are made, and that's one of the reasons why cancer occurs more frequently as we get older, is that as our cells divide and we age, mistakes are made, and those things sometimes are not corrected, and they accumulate over time. But these things are only in our tumor cells. So you really have to check the tumor. You can't look at a blood sample to find a somatic mutation in many cases. And then the last thing are these functional changes. So again, using my book analogy, I would consider these to be sort of handwritten comments in the margins of a book that alter your interpretation of a passage. And so there's a bunch of different ways that this can happen, but these can be more subtle changes to the how DNA is expressed and leads to protein expression, and sometimes just the outcome of how changes in the cells occur. And these can be tested for. There are some that I would think of that have been around for a long time. For example, estrogen status in breast cancer helps determine some types of treatment. We use that for certain types of gynecologic cancers too. There's something called HRD testing, which sort of is a BRCA-like pattern for ovarian cancer that helps to determine treatments for ovarian cancer, but doesn't show up in the actual DNA of the cells. It's an outcome of some other changes in the cell. And there's other factors called hypermethylation, which is a epigenetic change that causes changes in cells that can impact the response to immunotherapies. And then finally, something I think is really interesting, especially for clinical trials and immunotherapy trials, is there's something called HLA typing, which is a type of how our immune system is structured, and different people can have different genes in their immune system that can impact their response to immunotherapy studies. And these are all things that can be tested for, but don't necessarily show up in the sequence of the DNA. And that's why I think it sort of apply with our big analogy that this is sort of like the writing in the margins of a book. So getting back to this germline versus somatic mutation, germline mutations are in all of the cells. They're inherited, and you can find them in normal cells and cancer cells. Somatic mutations are only found in tumor cells. To find tumor cells, you need to get a biopsy of the tumor. Now, there's different ways to do this that we'll talk about, but the easiest way is to biopsy the tumor. Either you have tissue available already, or you perform a biopsy to get it. But germline mutations you can find from any cell. So you could get a blood sample, you could do a skin biopsy, you could do anything to get an evaluation of the cells to find out what the germline status is. And that impacts how we test for these types of mutations as well. But generally, blood tests don't pick up somatic mutations. We will talk about liquid biopsy here a little bit later, but that would not be found in all of the blood cells. So germline testing, as I mentioned, is usually a blood or a saliva test. The most common are BRCA mutation testing and Lynch syndrome testing, but there are oftentimes large panels of genes that we look at for different types of cancers. There are different gene panels that help us identify hereditary cancer syndromes that determine risk for other cancers. And now, as we get further into our understanding of precision medicine, these genetic conditions can lead to different treatment options. By far, I would say the fastest uptake for this has been in ovarian cancer, although in breast and prostate, there has also been a lot of data looking at this too. But PARP inhibitors have really become the standard of care for women with advanced ovary cancer, and they can be given in a variety of settings. But we really have to get germline testing to determine whether a woman is a candidate for a PARP inhibitor. But I'd like to think that down the road, we'll be seeing a lot more testing like this. Why is this? So the reason why this is important is, when are you going to use this data? So now we're using PARP inhibitors early in cancer treatment. So in the past, we used to say someone could get genetic testing anytime, 6 to 12 months after a diagnosis. But now we really are asking patients to get genetic testing done early, because it impacts not just their risk of other cancer, not just the risk of their family members getting cancer, but affecting their treatments. Similarly, we see with Lynch syndrome and the types of cancers, the colon and uterine cancer associated with Lynch syndrome, that there are immunotherapies with something called checkpoint inhibitors that can be especially helpful in patients who have the mutations that we see with Lynch syndrome. So right now, we don't have as many of these kinds of tests for other types of cancers, but I'm undoubtedly these are coming down the line, and there may be some that I've missed. But it is important to talk to your oncologist about genetic testing and whether it's appropriate for your cancer type. And to do that, it is important to find out as much information as you can about your family, about cancer history in your family. There's some types of cancer where we do genetic testing for everyone. For example, ovarian cancer. Any woman with an epithelial ovarian cancer, we would refer to a geneticist for genetic testing. But there's other types of cancers where genetic testing is only appropriate if there's a family history that suggests that there might be something going on. So that's why it is important, if possible, to get history from your family and determine whether seeing a genetic counselor would be helpful. So somatic mutation testing. So with this, as I kind of alluded to already, you have to test the tumor. The most straightforward way to do this, I think, intuitively and in most regards, is to directly biopsy a tumor. But there are new ways emerging to do this as well. Some types of solid tumors will shed tumor into the bloodstream, and these can be picked up, even though it's in very tiny quantities. These can be picked up and sorted and identified in the blood, and this is called a liquid biopsy. So solid tumor biopsies are more conventionally straightforward. Some types of tests, most tests allow some of the somatic mutation testing I mentioned, can be used from pre-existing specimens. So in a lot of cases, you don't need to do a new biopsy to get tissue for testing. And when I talk to patients about having surgery, I talk about this a lot. The default is to store tissue from surgery after a diagnosis has been made, and it's kept in a freezer for forever, basically. And if you want to do some kind of testing later, they'll bring out a piece of a saved specimen and send it off for testing. And even though the tissue is dead and like fixed in what we call paraffin, it can still be used to do testing. So it's kind of amazing that you could pull a piece of tissue out from, say, 3 years or 10 years earlier and test that and use that to base treatment decisions. So, however, there are some situations where a new biopsy might be indicated. So right now, in a lot of cases, we actually are not finding that there's a need to re-biopsy if tissue is available. But if there's no tissue available and a biopsy could be performed, that would be helpful. But surprisingly, I think to me, surprising that if you compare the results you get from somatic testing from a primary tumor and a recurrent tumor, at least for the gynecologic cancers that I care for, that there doesn't seem to be a lot of changes in the mutations of the tumor. So it's, as of right now, and this could change over time, but there doesn't seem to be a need to rebiopsy for the kinds of cancers that I take care of. Now, there are other types of cancers where that may not be true, and so it's important to talk to your doctor to see whether it's okay to use an older specimen or whether a new biopsy is needed. There are downsides to repeating a biopsy, of course. There's risk from procedures if there's a tumor in a place that can't easily be accessed, as well as the costs from a biopsy procedure that may or may not be covered by insurance. And those are complex issues in terms of whether a repeat biopsy would be tested. But oftentimes you can get the same answer from older material, and sometimes it's faster to get it from older material than newer material, and vice versa. Sometimes the tissue is off at another hospital and may take a long time to get the tissue sent, and if there's an urgent situation, maybe better to perform a biopsy, but those are sort of individualized decisions. So if you're needing to undergo testing, that's an important conversation to have. Is it better to get to use old tissue or to get a new biopsy, and what are the risks of a biopsy procedure in your exact circumstance? This does get to the next thing, and I think a lot of us, and I was just on a call earlier today with our national research group for uterine cancer, and we were talking about a trial using liquid biopsy and trying to correlate liquid biopsy results with tumor biopsy results for women with endometrial cancer. But the idea here is that if you have a tumor, even if the tumor is not in the bloodstream, that little particles, whether it's actual DNA or protein, will be shed into the bloodstream, and that these materials, even though they're in very tiny quantities, can be picked up and analyzed and can look for mutations that are associated with the tumor that's not in the bloodstream. And so this is a really exciting way to get less invasive biopsy specimens. You just need a blood draw rather than biopsying. You don't have to get anything from cold storage. And it may actually be that there are new uses for these liquid biopsies rather than just as a substitute for biopsying the tumor. There may be other reasons to do these biopsies. In some types of hematologic cancers or blood cancers, there are ways to follow response to treatment with looking at circulating DNA. In solid tumors, this is not quite yet ready for prime time, but this may be something that over time, there are commercially available tests looking at circulating DNA. But I think in many cases, that's not yet the standard. Right now, we still tend to use things like CT scans and exams and tumor markers. Like for ovarian cancer, we oftentimes use something called CA-125 to track response. And if it's elevated, then if someone's receiving chemotherapy, we like to see it going back down, and that can be a marker for response. But someday we may use liquid biopsies as a way to assess response to treatment. So there are other problems with it. Potentially not all tumors will be shed into the bloodstream. And then, what do you do if you get a conflict between a mutation in the tumor and the bloodstream? Which do you go with? These are the kinds of details in a technology that's kind of still being figured out, that we don't have all the answers for. And these are areas where there may be differences across different disease sites, but I think these are things that can be important to discuss with your oncologist, whether a liquid biopsy would be useful. These are things I think that are worth discussing for patients with solid tumors. So as I mentioned, that liquid biopsy results can change, and we don't totally know what to do with this yet. I think this is an exciting area. Like if you were to do a liquid biopsy of someone at diagnosis and then repeat later, what to do with that information. We don't have all the answers to things like that yet. So what about more broadly, what I would call next generation sequencing, or NGS. So these are somatic mutation testing panels. Remember I discussed earlier about using specific markers to determine a treatment for a type of cancer. I think I had mentioned about EGFR mutations for lung cancer. That's really just looking at one gene in one tumor to decide one treatment. These are panel tests with oftentimes hundreds of different genes being looked at. We can look at DNA, you can look at RNA, both of which can be useful, and a variety other, something called copy number variations, all of which can be used to help guide treatment decisions. These are generally covered by insurance now, but I don't want to make any promises about that. And you can see the names of some of the companies make this, and I have no specific endorsement for any of these. I have no dog in the fight. And I think that there are various pluses and minuses to each of these tests. But overall, the goal of these kinds of tests is to create a panel of somatic mutation testing to look for mutations that may pop up in the tumor. And why this is important is, so we get back to that point about an EGFR mutation. EGFR mutations may occur in 1% of ovarian cancer patients. That may be something that's not worth it from a cost standpoint to test by itself for an EGFR mutation in someone's tumor. It's costly to run these tests. But if you have a panel where each of these tests, you have 400 things, and each of which occurs in maybe 1% of patients or 3% of patients, you might put together enough tests that can be run together that will identify things that can be used to guide treatment that's both quick and straightforward, and also cost effective, so that we're really providing personalized medicine even for things that might be uncommon to find in a particular type of cancer. So I mentioned that these tests can assess different things. We talked about DNA and RNA, but the most important thing is that they're identifying mutations that may have some prognostic impact. So in terms of how will someone do, or treatment. A lot of these tests do require comparing tumor tissue to normal tissue, although some of them can just be looked at. If you know that there's a particular mutation in the tumor, you can just treat based on that. But some of them do require comparing normal tissue to tumor. And when this is necessary, they can do it multiple ways. Sometimes a tumor biopsy will have normal tissue mixed in together, and they can compare those two. Sometimes it can require a separate biopsy of a normal tissue, but the most common way is to get a blood sample done at the time of the analysis. And so there are some tests that only look at normal tissue, and I think I would think of this as genetic testing is looking at normal tissue, right? Getting a normal blood sample and looking for genetic mutations. And then some of the immune function testing can look at normal blood samples or a bone marrow biopsy to determine whether a particular treatment may be effective. So how do we use this? Unfortunately, when I order next-gen sequencing tests for my patients, I try to set the appropriate expectations for it. Sadly, most patients who have this kind of testing done for the kinds of cancers I treat, and maybe different for others, but don't have what we call actionable mutations yet. So a lot of times we may either find mutations in things that we don't have good treatments for yet, or we can't use the test, can't use a drug available to treat the person's tumor because we don't have FDA approval, or we just don't find any actionable mutations. And that does happen sometimes. So it doesn't work for everybody, but sometimes we do find interesting things and useful things. But there are several ways that next-gen sequencing can impact treatment. And I would divide these into 5 broad groups: sort of hereditary cancers, there are immune-driven cancers, there are testing for response to new targeted drugs, there are chemotherapy sensitivity assays, and then there are markers that can help predict or allow someone to enter a clinical trial. So when I think of hereditary tumors, I think of, for me, for treating ovarian cancer, looking at patients with BRCA mutations. And interestingly, if from a treatment standpoint, if a patient has a BRCA mutation, hereditary one, and or they just have a BRCA mutation in the tumor, both groups respond to PARP inhibitors. We also have patients who have BRCA-like tumors that don't have BRCA mutations anywhere, but their cells look like BRCA cells. And there's a lot of detail to that, but it's called homologous recombination deficiency. But patients with homologous recombination deficient tumors also, in ovarian cancer, also respond to PARP inhibitors. PARP inhibitors were specifically designed to address DNA repair, especially in patients with the BRCA mutated cancers. And so to varying degrees, we're using these tests in breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer. So this is one interesting way that we are using these kinds of tests to provide precision, patient-centered treatments. Next, we look at immunogenic tumors, and this is a huge area of research and clinical development over the last 5 years. It's amazing how much progress has been made on this. Most of this data is looking at something called checkpoint inhibitors, but there are other aspects to it as well. But these genes also assist with DNA repair, but in a different way. There are hereditary mutations in 4 different proteins that cause something called Lynch syndrome, which leads to higher rate of lots of different types of cancers, but the big ones are uterus, colon, and ovarian cancer. But there are other types of immune-like tumors that have high what's called PD-1 expression or high tumor burden that leads to kind of an immunogenic type cancer where immune therapies are effective. And there are other checkpoint inhibitors as well, but the one that I use primarily for treating gynecologic cancers is pembrolizumab, or the treated name is Keytruda. It's a checkpoint inhibitor. But really exciting part about this is the first cancer drug that was approved based on a marker, not a tumor type. Every single other cancer before that, even the ones that were marker driven, were based on a cancer type. So if a patient has a DNA mismatch repair deficient cancer, whether it's from Lynch syndrome or they have a mutation in their tumor, or they have these other factors called MSI high or high tumor burden, they can receive pembrolizumab. Even if it's a cancer where that's a rare event, you can give pembrolizumab and it can be quite effective in some patients with these types of cancers. This is, to me, this was incredibly exciting that the FDA understood that we're moving towards treating patients based on markers rather than where the cancer comes from. It really opens up a lot more options in terms of how we treat patients, and really should be opening our eyes to how we treat patients based on markers. There are other ways that we use these drugs used for patients who have PD-1 positive tumors, and this shows that kind of the nuance of it. Patients who have PD-1 positive tumors, it doesn't seem like all patients with PD-1 positive tumors benefit from pembrolizumab. Cervical cancer, gastric cancer, lung cancer, patients with PD-1 positive tumors have been shown to benefit from this treatment, but not in all diseases. So there probably will ultimately be some kind of in-between ground where we have a sort of a mixture of disease site-driven treatments and marker-driven treatments that are independent of where the cancer comes from. And it can get kind of complex. Even as an oncologist, these things can get kind of complex, but if you don't test, you won't know. And then the next thing would be looking at other types of treatments independent of tumor origin. And I think getting to this, I just mentioned this about the pembrolizumab with the DNA MMR deficient cancers, but there's another one that has subsequently been improved. So patients with NTRK gene rearrangements tend to have actually really impressive responses to a type of NTRK inhibitor. For many types of cancers, these mutations are very uncommon, but there have been some really remarkable reports of patients. These are the kinds of mutations we're talking about where maybe it occurs in 2% of cancers. But if we can string together a lot of different genes that may be targetable, but if we say 20 years from now, we have 50 different treatments that target cancers where we find it in 2% of patients, it means that we'll have a much bigger bag of drugs to use for specific circumstances, and we're more likely to find targeted therapies for each individual patient. The problem is that the mutations are rare, and that it can be hard to develop drugs for tumors with rare, uncommon mutations because you have to accrue onto clinical trial, which I get to in a moment. But this is really probably the main limiting factor for some of this, is that these can be rare mutations. But we are getting better at working together to try to test things that are, what to say, agnostic to tumor origin. So there are some other more specific examples that we encounter routinely. So HER2 status is a common marker in breast cancer. We've subsequently found that certain types of uterine cancers are HER2 positive, and now Herceptin or trastuzumab is a standard of care for certain types of high-grade uterine cancer. There is some really exciting work looking at something called HDAC inhibitors for patients with ARID1A deficient cancers, and this is a little not quite as far along developed. But we also have MEK inhibitors, which are appropriate for certain types of tumors with BRAF and MEK mutations, and we use this routinely in low-grade serous ovarian cancer, but we also see this being used in melanoma and some types of lung cancer. So these precision tests can be used to identify mutations that in certain circumstances may impact treatment decisions. And then I would like to briefly mention chemotherapy sensitivity. I think this was something that there was a lot more interest in perhaps 10 years ago, but still does go on to some degree. So can we find genes that correlate with standard chemotherapy response? And there are certain mutations that are associated with particular mutations and are linked to response to chemotherapy. But what I would say is that in general, these types of mutations that are linked to standard chemotherapy drugs are not strong enough in a lot of cases to say that you won't use a drug because they're not perfect tests. I tend to think of chemotherapy assays. It's not something I use routinely for the kinds of cancers that I treat, but I would generally think of these as more of decisions about guiding the sequence of therapy rather than what I would use, because I would maybe prioritize drugs that are more effective based on some of these mutations. And I might move something up in the sequence of drugs that I would use, but I wouldn't omit something. For example, carboplatin and cisplatin are incredibly important for ovarian cancer, and I would never omit those drugs if there was a sensitivity assay that said that there was a lower chance of someone responding to it. And then finally, the last thing is using these assays to guide clinical trials. These tests are done for standard treatment, but they actually do provide information about clinical trials. And a lot of the companies that make these commercially available tests will, if they find a mutation, they scan the literature for trials that may be available for a specific mutation, and will provide information to the provider and patient about those trials. A lot of the trials tend to be early phase, but there are some non-disease specific, so trials for patients with a mutation X, regardless of where it comes from. Those sorts of things do exist out there. But one important thing I think that is important to note about this is that most of these companies don't update their recommendations over time. So most of the reports are only listed at the time that the test was ordered. So it's very important, if you have a cancer where a mutation was identified, that your provider is looking back to see if trials may be available in the future, because the clinical trial landscape is changing all the time. And so we have to find ways to update this, and the companies don't tend to do that. And then the final thing is that it can be that there may be a trial available, but it might be a very intensive phase 1 trial, and it's available in Germany or across the country, and those sorts of things can be challenging in terms of participating. So molecular testing really is a work in progress. A lot of patients don't yet have mutations that are actionable, but that number is increasing all the time. We do tend to see insurance coverage effective for most solid tumors, but it's not a guarantee. It's important to check for your exact circumstance. And you do have to have tissue available for testing. I think liquid biopsy is coming along, but it's not as well established as tumor tissue testing. So I just would like to leave you before we get to questions with a few pointers about how I think to use this information. So the very first one, and I think maybe sometimes we wouldn't think of genetic testing as the same thing as, but it is molecular targeted, can be used in some cases for molecular targeted treatment, amongst all the other reasons to get genetic testing. But not all cancers have a genetic link. But it doesn't hurt to ask whether referral to genetic counselor or getting genetic testing done is appropriate. And I do recommend that patients, rather than just get tested in their oncologist's office, meet with the genetic counselor, because they sometimes uncover things that I don't know about. That's their specialty. Sometimes they'll find a mutation and something rare that I hadn't thought of, and those things are really important to take the time to meet with a genetic counselor so that the correct tests are ordered. And then the next thing is that genetic testing does take time. And as we start moving results from genetic testing earlier into treatment, it's important, especially for ovarian cancer, that we test early so we have those results back, because it can take a few weeks to get results back. So you won't have results back instantaneously. And then finally, it is important to recognize how genetic testing may impact family members and risk of other cancers. And so it's important to meet with the genetic counselor to help manage the full spectrum of issues that relate to that. So what about tumor testing? Ask your provider about tumor testing. So things you might want to ask: is there tissue available to do this? Would I need to have another biopsy? Is a biopsy safe and appropriate? Sometimes biopsy is not possible, unfortunately, just because a tumor maybe it's too small to see, or it's in a place it would be dangerous to insert a needle. So in those cases, maybe a liquid biopsy would be appropriate. Is a liquid biopsy useful in your particular circumstance? And then, what kind of tumor testing is appropriate? Some of it can be these commercially available next-gen sequencing tests. Sometimes it's looking at hormone receptor status or some other factor that doesn't require a send-out test. It can be done at the lab at the hospital. And then, are there clinical trials available based on the results? So these are really incredible things that we see trials that can change our management. And all the things I mentioned before where they're now standard were clinical trials initially. So it's important to ask about that and to re-ask if you have other mutations. So, and this gets to that last point about updated molecular testing. So trials change over time. So you may want, if mutations are identified, ask again, has anything changed? Are there trials available now that weren't before? And you can actually do this yourself to some degree. I recognize that this can be hard, but the clinicaltrials.gov website includes a list of all clinical trials, and it may be worthwhile just putting in the particular mutation into the search results there. And sometimes you might find something interesting, and you can sort based on your location. And while I do think it's the provider's responsibility to be helping with this, I think this is a way that patients can be empowered to look for studies themselves as well. So I think not every molecular-based test is available through these commercial platforms. So there are some trials available, and I do encounter this sometimes where a patient may need to have extra testing that's not commercially available to decide whether they're a candidate for a trial. Those things are a little bit harder to coordinate because obviously we can't order tests for things that are not standard yet. But oftentimes we can refer a patient, either I have it here or at another institution, we can refer the patient to get the test done so that we can determine if they're eligible for a study. So that those are things that can also occur.